Hello, everyone. Thanks for joining. Today's session, we're going to go through lacrimal disorders. We're going to sort of touch on how to sort of approach a patient that comes in with a potential lacrimal disorder, the things to consider in terms of potential causes, and what sort of investigations you're going to do in your clinics, and also some management options near the end. So I was kind of trying to think about how to kind of best explain how to approach lacrimal disorders because if by missing certain aspects of the actual normal physiology, you can essentially forget to check certain things, and you might sort of start to kind of go down a rabbit hole with what you think might be wrong with the patient when there are some things that are slightly more preliminary that haven't been checked. So if you think about the lacrimal system as sort of three parts, you've got the development of the tear film. You then have its distribution over the ocular surface, and then it needs to drain. And if any one of these three things is wrong, patients can either present with either a problem, for example, with dryness, but it tends to be a problem with Epiphora, in terms of what we're going to talk about today. So dryness is for a different day. So with the development, you kind of, we're all going to be aware that there are sort of three main aspects to the tear film. You've got your sort of mucin layer that comes from your conjunctiva. You've got your more watery layer that comes from your lacrimal gland, and then the sort of fatty layer that comes from your lids. And those three together need to be working well for your tear film to be an adequate tear film. So if any one or a combination of those three parts are not optimal, then there's potentially going to be problems. So if your conjunctiva is not it is not healthy, you don't have enough mucin being released, those tears are not going to properly stick to the surface of the eye. If your aqueous humor is reduced for any reason, either something like an autoimmune disorder or potentially even previous trauma to lacrimal gland, then again, it's going to be problematic. And any lid disorders is also going to affect the fat layer of that tear film. You then have the distribution over the ocular surface. So again, any irregularities on the ocular surface, your blinking system sort of moves the tears over the surface of the eye. So any problems with your lid positioning, any problems with your blink, things like a lag of thalamus is going to affect the distribution of those tears. And then the drainage is also associated with that lid positioning. So if that lid positioning, so a bit of like ophthalmos may not distribute your tears properly, but then also if you've got an entropion or you've got an ectropion, that's going to affect the draining because your ducts aren't going to be positioned correctly. And if you have quite a bad ectropion, it may decide your tears may pool at the bottom. And obviously your ducts also need to then be patent. And that includes all the way from your punctum, your canaliculi, your lacrimal sac, and your nasolacrimal duct, all need to be patent for a for a properly draining system. So if you think about it in those sort of three parts, then when you're assessing the patient, it's much easier to sort of make sure that you're checking all the different parts of the lacrimal system from start to finish to try and actually find what is wrong with the specific patient in front of you. Because really some simple measures can make a big difference to a patient, if you've correctly identified the problem. So where it can go wrong is essentially with Epiphora, where you'll get lots of tearing to the eyes, and that could be because of one or a combination of problems with what we've just discussed. You have your sort of classic nasolacrimal duct obstruction for whatever reason, and we'll talk about that specifically. And then there's also the infections that can happen as well in the system. So with Epiphora, it's a very common complaint, and actually, on some of my plastic rotations, one of the things that I've learned the most is there are certain sort of key questions that you can ask your patients, that can help you sort of lead towards the actual cause of the problem. And remember that Epiphora and dryness can be very closely related. So Epiphora can be a reflex response to dryness on the eye. It can be a problem that, for example, if the patient has an evaporative dry eye with a problem with their fat layer, then they're going to be creating more tears. If they have a problem with their tail film in any way, the eye can be sort of as a reflex, making more. So sometimes Epiphora is actually a problem of over production rather than under drainage, essentially. So you'll basically have a patient that comes in, and usually what they'll tell you is that my eye or eyes or whatever combination just keeps watering. And your job is really to try and actually figure out what that really means. Sometimes, the patient will be sat in front of you saying this, but actually their eyes are completely dry. So you want to understand if if their watering is both indoors and outdoors. Is it just outdoors? Is it only in sort of cold winds, or if they're sat there sort of just at home at rest, are they also still watering? And another sort of useful question is actually specifically where the watering is coming out from. So if their watering is coming from their inner eye versus their sort of outer eye or more the lateral end, and if it's coming out from the lateral end, sometimes that's actually more of a problem of positioning and anatomy. Whereas with your inner eye, it can sometimes be a problem with drainage. Is it seasonal? Does it change with the weather? And also just take a systemic review. So, for example, do they have any evidence of Sjögren's? Is their mouth also dry? Do they have any sort of inflammatory conditions elsewhere? For example, if they have a known GPA, are they possibly do they have polyps in the nose? Is it a problem with their drainage? Have they had previous trauma, any previous surgeries to the nose or the face? So it's very important to just get a good systemic review. And then in terms of your assessments, you're obviously going to do the clinical exam, and then there's a few different tests that you can do in clinic from dye disappearance, syringing, and imaging as well, later down the line. So whenever you're coming up to your clinical exam, again, so if you just go back to that lacrimal system, you want to make sure that you're checking all of this. So you're looking at the lids, you're looking at where they're positioned. Are they appositioned against the globe properly? Is there an entropion? Is there an ectropion? Is there laxity, which means that they may not be draining properly? Is there any scarring? Do they have any sort of meibomian gland dysfunction? Look at the puncti. Are they positioned well across the globe? If there's an entropion, does that mean they're being hidden or they're being blocked by the positioning of the lid? Are they very tight? Are they very narrow? Are they scarred because of a previous, for example, adenoviral conjunctivitis, or previous conjunctival infections or inflammatory conditions? Are there any concretions that need to be removed? And then you want to over here may potentially do some syringing that can help you again assess the patency of your canaliculi, and also the patency of the entire lacrimal duct, lacrimal system, sorry. But then also if you can't get the syringe through the punctum, that might be giving you a bit of a red flag that actually potentially what you're looking at is a very tight punctum. Then check your ocular surface. Is there any obvious inflammation of the conjunctiva, any irritation? Go down into your fornices. Just check that there isn't anything that you're missing from an inflammatory point of view in terms of your conjunctiva, and then assess the tear film. Is there kind of quite a large meniscus on that lower lid? What's the breakup time when you put in some fluorescein and you're asking the patient not to blink, and assess just the adequacy of that tear film and whether or not there's an element of an evaporative component as well, to the problems that you're looking at in front of you. So with Epiphora, there are certain assessments which I touched on. So with dye recovery, what you're essentially doing is just applying fluorescein to the surface of the eye, and that's recovering it from the nostril. So this isn't necessarily always done in day-to-day practice, but especially in your exams, it will come across. So you put a cotton bud in the nostril, and you're trying to recover the fluorescein or the dye from your lacrimal system. So a Jones 1 is a physiological assessment. You're just putting a drop of fluorescein on the eye, and you're waiting for that dye to pass through the lacrimal system physiologically. So there's no syringing, there's no extra pressure. Whereas Jones 2, you're actually going to syringe the fluorescein through, and you're going to see whether or not you can get it. So Jones 2 sort of assesses the fact that the system may be patent, but it may require a bit of pressure, potentially pointing you down to a possible functional component to nasolacrimal duct obstruction. And then there's this sort of pseudo Jones 3 kind of test, which is essentially a post DCR to check that the system is actually patent. Syringing is probably what you're most typically going to see, where it's a very similar kind of process to Jones 2, but you're essentially just syringing saline through the system, and you're asking whether or not they can taste that salty fluid at the back of their throat to see whether or not the system is patent. But while you're doing that, one of the things that can be helpful is actually also looking at where the regurgitation is taking place. So is there regurgitation through the lower punctum itself? Is there regurgitation through the upper punctum? And these are all things that can help you understand potentially where the blockage is, or is there just a complete regurgitation and there's nothing going down to the back of the throat? And assessing both eyes is also really helpful. So even if the patient has unilateral symptoms, by checking both, you can actually also get a feel of how much pressure is required to push that fluid through, how easy it is to pass the syringe through the punctum, and through the canaliculi. So it's helpful to see whether or not you're looking at just a bog standard NLDO, or is there actually a system with the canaliculi? Is there a problem with the punctum? And by checking both sides, that's really helpful. Your Sherman's test, again, you may not see this all the time necessarily in clinical practice, but essentially what you're doing is you're putting a bit of paper on that lower lid and you're trying to see how much of that tear film is being produced. And there's sort of two ways to doing it. You're either going to do it with or without anesthetic. And the idea is you're either going to be assessing the basal secretion. So basal secretion, you have a normal basal secretion of tears and of aqueous from your lacrimal gland, but then there's a reflex to any sort of irritation or foreign body on the eye, for example. So if you put some anesthetic and the eye is nice and numb, you will assess the basal secretion of the eye. But if you don't have any anesthetic, then obviously there will be the basal secretion plus the reflex secretion. So you can assess the sort of problems between the two, and you can see whether or not there's an issue with the basal secretion. So your reflex secretion might be okay, but actually there's just an underlying problem with an underscore of a low production of your aqueous tear film. And then there's imaging. So your DCG is a classic sort of, you're syringing the dye through, and then images are taken to see whether or not your ducts are patent. But to be honest with you, a lot of the plastic surgeons I've worked with will basically tell you in terms of sort of clinical use, the DCG is not really that different to doing something like syringing in clinic. So it doesn't necessarily add too much if you've done your syringing well. What can be really helpful though is a DSG. So there's a drop of a radioactive isotope that's put on the eye, and then that's just, with nuclear medicine imaging, that's just the physiological tear flow through the lacrimal system is then assessed. So that can be actually sometimes more helpful because obviously it's a physiological system. So if you're doing it, it's quite similar to your dye recovery where you're just doing a Jones 1. But obviously with the radio opaque images, it's much easier to see whether or not your actual systems are patent. And if they're not, you can then really easily see where the problem is. But DSGs are really helpful. So the scintigraphies are really helpful if you're concerned that there might be a functional component to the patient's nasolacrimal duct obstruction. So then how do you manage? We've kind of, spoken about this, but really managing a watery eye depends on a good assessment and a really sort of strong basis on what it is that you're trying to treat. And there are essentially three problems. Either there's too many tears being produced, either there's too little drainage, so there's not enough of it being brought out of the system, or there's a problem with the pumping of those tears through the system as well. And your job from the assessments that we discuss is to essentially think about therefore what is really the problem. So with too many tears, for example, you're looking at either there's a problem with the basal secretion, so there's too much coming out, and that can either be a sort of prosecretory drugs, things like pilocarpine, or for example, autonomic disturbances. And then you've also got a problem with reflex tearing. So again, is there like a local irritant? Is there some sort of foreign body? Any sort of, for example, in this picture there, you might see a trichiasis, there's an entropion causing irritation of the ocular surface with lashes. Is there a chronic disease of the ocular surface? Is there an inflammatory condition, mucus pemphigoid? Is there any sort of corneal issues? Is there a contact lens that's causing this? So those are all problems in terms of there being too many tears, in which case you would sort of try to manage it appropriately. So with basal secretions, there are certain drugs that you can give to try and reduce that autonomic disturbance. If there's a problem with the actual irritation of the surface, treat the irritation. Is there any issue with where the lashes are pointing? Would the patient benefit from electrolysis? Do they need steroids to help any settle ocular inflammation? So see whether or not the problem is with too many tears being produced. And then is it too little drainage? So for example, is there a sort of punctal issue? So are they small? Are they blocked? Do you have, for example, is there any scarring across the punctum from a previous adenoviral conjunctivitis or an HSV infection? Is there, from a previous trachoma, cicatricial disease? Is the punctum actually just completely blocked? The canaliculi, very similar things can happen to it. So again, any scarring can block it. They can get these concretions, like I said. Chronic infections can block your canaliculus. Then the lacrimal sac. So again, if you think about it, we're basically working through the lacrimal system. So with your lacrimal sac, they can be blocked either by growths, for example, tumors, things like granulomas, infectious fungal infections. So consider whether or not your lacrimal sac is blocked. And This is perhaps sometimes where imaging is really helpful because you can actually see whether or not there are any growths within the system. And then the nasolacrimal duct finally. So again, there's the congenital problems with just a, delayed opening of the nasolacrimal duct where, you're waiting for those first 12 months to see whether or not the child can actually eventually improve by themselves. Or is it later on in life? So does it just happen idiopathically, which for most patients, that's kind of what happens. Is there a traumatic sort of etiology to it? Is it kind of post, have they had radiotherapy to the area? Is it all sort of post-treatment? And then again, we mentioned GPA, things like tumors and things like that can all block your nasolacrimal duct. And then finally, and this is sometimes a bit softer and it might be a bit less obvious to you immediately, but actually the problem might be with the actual pumping system of your tears. So the way your pump works, it's not just a completely passive system. There is an element in terms of the way your blinking works, the function of your orbicularis can all contribute to an efficient pumping of tears through the system. So if there's any malpositioning of your lids where the tears aren't going to move properly, or if there's a problem with your blinking, if there's an issue with the tone of your lid, so there's a laxity problem, there's a weakness of your orbicularis with, for example, a seventh nerve palsy. All of these things can then contribute with insufficient pumping of the eyelids, pumping of the tears, sorry, and then that gives you that epiphoria. So what you can see here is there's lots of different contributory factors to the watery eye, and a really, really good assessment can help you kind of, for example, the patient may completely avoid surgery and because actually the problem is, for example, with too many tears and there's something else for you to fix. And actually, by trying to go and do a nasolacrimal duct or a DCR, sorry, you're opening something that's already patent. Or actually, the opposite is equally important, where you might be trying to go down the line of saying that this is a problem with an ocular inflammation or surface inflammation. So I'm going to give you lots of lubricants. I'm going to give you some steroids. And actually, their problem is just a blocked duct. So no matter what you give them, you're just going to make the issue worse. So it is really helpful to have a really, really good assessment, checking your lids, checking your ocular surface, checking your actual the punctum, the canaliculi, the lacrimal sac, and the nasolacrimal duct to see where exactly the problem is. So we'll talk about some infections. So again, if you think about it, we're just going to talk about, again, the canaliculi and then down to the lacrimal sac. You can get a canaliculitis. Now, for the purposes of your exam, it's typically an actinomyces israeli. It can also be fungal infections, things like candida, aspergillus. You can get viral infections as well. And these are patients that can get recurrent epiphoria when the inflammation is when the infection is active. They can get this pouting of your punctum because of that swelling that's happening along the canaliculi. And then importantly, you're not going to get any swelling around the lacrimal sac. You're not going to get any swelling around the nasolacrimal duct. It will be purely along the canaliculi. And these are patients that potentially may need a punctoplasty, opening that punctum up and then just completely irrigating it through. And you may even consider irrigating through something like an iodine to just sterilize the area. And then you've got your lacrimal sac. So basically a dacrocystitis. Now remember, dacroadenitis is a problem with your lacrimal duct, your lacrimal gland, sorry. So a dacroadenitis is a lacrimal gland issue. So we'll talk about that when we start talking about orbital problems. But a dacrocystitis is a problem with your actual sac. So this, adenitis coming from the fact that you have a lacrimal gland, and cystitis coming from the fact that it's essentially a cyst because it's a sac. So you've got the acute dacrocystitis. So for patients with nasolacrimal duct obstruction, you may actually find that they're coming in with recurrent acute dacrocystitis, typically a staphylococcus or a streptococcus. So again, your sort of commensals on the skin, and they get a painful, swollen, sort of red a lacrimal sac, and that can sometimes discharge with some pus. And you're essentially going to treat these similarly to how you treat a preseptal cellulitis with some coamoxiclav. And potentially you're going to want to do a DCR down the line because the underlying issue is a nasolacrimal duct obstruction commonly for these patients. And just for the sake of your own kind of, this image at the top left is your sort of typical canaliculitis, and this in the bottom right is your sort of dacrocystitis. So you can see the difference in terms of where the swelling is exactly. And then with a chronic dacrocystitis, these are patients that can have sort of a mucocele, again, nasolacrimal duct obstruction. And really what these patients need is opening up of their nasolacrimal duct. So these are patients who are eventually going to need a DCR. So that brings us to then talking about what a DCR is. So many of you will have seen this if you're on your plastics firms. There's two sort of main approaches. You've got the more traditional external approach where you come in from the front, open up next to the nose and then create a passage. And then you've got the endonasal approach where you come up through the nostril and do it all from the inside. And essentially what you're discussing with the patient is that it's all about sort of success rates and scarring. And traditionally, the thinking is that external DCRs tend to be slightly more successful. In the more sort of recent literature, it suggests that the success rates are starting to balance, and that's probably to do with the fact that the surgical procedure is actually getting more efficient, and also by involvement of your ENT colleagues, you can actually get much better results. Now, the benefit of having an external DCR is it's just done purely under oculoplastics. Like I said, traditionally the success rates are better, and that's usually because you can actually just see the fact that you've gone all the way through and you've made a nice big hole. Whereas the benefits of the endonasal approach are that you don't get the scarring, you're coming in from the bottom. But the problem with the endonasal approach is that a lot of the time for you to do that properly, some oculoplastic surgeons will want to work with ENT surgeons. So just timing for the patient might mean that they're waiting a bit longer for the surgery. Now, if it's the second time you're coming in to try and do a DCR and someone's had a previous DCR, what you'll find is actually a lot of the problem is not necessarily that the whole thing has closed up, but just that there's a stricture. And sometimes if there is a stricture, all you need to do is go in endonasally and opening things up. So sometimes you might want to consider coming in endonasally if you've done a previous external DCR or vice versa. What will happen just before the surgery? Your anesthetic colleagues will help you out with either like a Moffat solution or some sort of cocaine for the nasal mucosa, reduce the amount of bleeding, reduce any swelling. Afterwards, you're telling the patient no hot drinks or food for about 12 hours, sleeping with their head up for a couple of weeks, no nose blowing. And then any nosebleed should really be taken seriously because epistaxis can be quite dramatic. Then you're considering your follow-up. So these are usually, if you've come in for an external approach, these are patients who are going to come in after a couple of weeks to have those sutures removed. But really importantly, those tubes do really need to stay in for a couple of months to ensure that while the healing is taking place, the passage that you've created isn't then just scarring up. So they'll come in 2 months later for a tube removal, and then you may see them 4 or 6 months after that to just make sure that the surgery's been successful and there's no recurrence of their symptoms. There's also a sort of variation of the DCR surgery where if from your syringing you actually think there's a problem with the canaliculi as well, there's a canalicular DCR where you're actually putting a Jones tube as well to try and open up the canaliculus, and you're not just actually just creating a passage for the nasolacrimal duct. So there's a slight sort of add-on procedure depending on where your problem is. So just to kind of summarize the session, there's lots of different parts of the lacrimal system, and it's really important to just consider all of them when you've got someone coming in with either dryness or epiphora. So consider where the tears are coming from, consider how they're being distributed across the surface of the eye, and then consider how they're being drained. So remember, you need a good tear film, you need a very receptive ocular surface for that tear film, and then you need a functional drainage system for everything to be running well together in tandem. So just consider all of that when assessing your patient and make sure that you're kind of quite confident about where the problem is, because you'd be wasting your time and wasting the patient's time to be trying to treat something that actually isn't the cause of your issues. So a good history, a good examination can really help direct your treatment for these patients. So thanks for joining. Just a quick run through of your sort of lacrimal system, the problems that can happen. And as we start to talk about different orbital issues and different sort of, during either the cornea series, looking at different problems with the ocular surface, problems with your lacrimal glands, when talking about things in orbit, we will come across other things that can then cause epiphora. But this was more a session to just sort of explain how you're approaching it, how you're assessing it, what you're thinking about, some of the infections, and then how to kind of what the basis is of a DCR. So I do appreciate your feedback. Please do remember there's just a quick link in the description. It takes a couple of minutes. So thank you very much for joining, and then we'll see you at the next one.